For women with simple vesicovaginal fistulas who haven't had radiotherapy, because the outcomes are far better in expert hands, in expert centres, I would always advocate referring patients, regardless, to reconstructive surgeons with expertise in that area. If you are miles away from an expert surgeon, if your patient doesn't have the facility or the ability to travel, then it would not be unreasonable, if you've had appropriate training and mentoring, to attempt to repair a simple vesicovaginal fistula. But you need to make sure that your patient's informed that the outcomes are never as good as they are when the repair is performed by an expert. For patients who've had external beam or brachytherapy for treatment of their pelvic cancer, I don't think there needs to be a standard per se follow-up in terms of urinary symptoms. I do think patients need to be well informed and have written information leaflets about what symptoms they could develop and when they should seek help. If you were going to offer regular follow-up, I think a simple flow rate, residual volume and a symptom score and assessment for incontinence. You could also look at creatinine or an ultrasound KUB. That's possibly overkill given the volume of patients who are having radiotherapy for their pelvic cancers. Any woman with voiding difficulties who describes poor flow rate, frequency, urgency, I would suspect of having outflow obstruction, but be cognizant of the fact that they may also have an underpowered detrusor or detrusor hypocontractility. Initially, a flow rate and post-void residual is helpful, but it doesn't exclude a low pressure, low flow situation. I think the first investigation of choice for these women should be video urodynamics and a urethral pressure profile. Video urodynamics to see whether there's high pressure, low flow, classic for obstruction, or low pressure, low flow, classic for hypocontractility. But you can have end stage obstruction that gives you low pressure, low flow, and hence the urethral pressure profile. The urethral pressure profile will show you if you've got a high tone, non-obstructive sphincter, Fowler's type syndrome. It will show you with catheterization difficulty if there's a physical obstruction, a stricture or a diverticulum. And if it's all normal and the urethral pressure profile is normal or low, then you're looking at a classic hypocontractility situation. I don't think it's a diagnosis you can make just with simple non-invasive testing because it's so subtle. The outcome of end-stage obstruction and end-stage hypocontractility is low pressure, low flow.